actually our speakers will be able to see your hands go up, or if you don't have a hand facility, if you're on a phone, just put your hand up and or just say, can I ask a question, if all else fails. So without any further ado, I will hand you over to Anna Cliff, who, as I said, is one of our occupational therapists.
And just before Anna starts, I'm just going to say I've started recording this. So if you don't want to be seen on camera, turn your camera off, because we will do our best to be able to share this with you. We've had some IT issues which have meant we've not been able to share, but if we can, we will, both with you and anybody else who's missed the meeting tonight. So here we go. I'm going to share my screen now and Anna will take over.
Okay. Hi everyone, my name's Anna Cliff and I'm an occupational therapist and I work at Royal Shrewsbury Hospital and I'm based on the short stay medical ward there. So this evening I'll be giving you a short presentation about what the occupational therapist's role is in supporting individuals living with COVID-19. Just to say, the credit also goes to Gemma Stiles for this presentation. We put the presentation together. She's the therapy quality improvement lead for the trust and her background is in occupational therapy. However, unfortunately, she's not able to be here today to present. So since the beginning of COVID, the population has seen an increase in patients requiring support with symptoms linked to post-COVID-19 syndrome. So we've gone to the next slide, that's great.
Oh, sorry.
No, that's fine. Next slide, please.
We're there. Oh, do we not want, do you want the next one as well?
No, that one's perfect, yeah.
Okay, sorry.
So no, that's fine. This slide just gives you a brief overview really of what I'll be talking about in this evening's presentation. So just a definition really about what is occupational therapy for those of you that aren't too clear. What role has occupational therapy got to play when working with people with long COVID? I've then put together a little case study to hopefully help highlight how the occupational therapist could help somebody living with COVID. And then I'll go on to talk about a little summary. Next slide, please. So I've put here just a little definition about what occupational therapy is. So occupational therapy takes a whole person approach to both mental and physical health and well-being and enables individuals to reach their full potential. So really, in essence, our aim as occupational therapists really is to help individuals to function as independently as possible in the activities that they need to and they want to do, and really activities that are meaningful to them. So occupational therapists do this by mainly identifying and eliminating environmental barriers to independence and participation in normal daily life. So I really believe that a key element of COVID recovery is having a skilled and diverse workforce that can address the complex rehabilitation needs resulting from the pandemic. So what I mean by a skilled and diverse workforce is different professions all working together. So occupational therapists, physiotherapists, dietitians, speech and language therapists, etc. Next slide. So why occupational therapy? What can we do to help? So as experts in holistic rehabilitation, occupational therapists have a vital role to play in addressing the debilitating effects of COVID-19. So we offer a very personalised and occupation-focused approach to care, and we support the recovery of people experiencing functional challenges arising from the virus and its treatment. So just to give really an example of this to reinforce the functional element that we very much play as occupational therapists. So a dietitian, for example, part of their role could be, helping somebody in relation to their diet and advice on what they can and can't eat. However, that individual, for example, might not be able to lift up a knife and a fork to eat. So from a functional perspective, we would support, that's one of the things that we would support them with. The Royal College of Occupational Therapists state that it's critical that individuals who have confirmed COVID-19 have access to rehabilitation in order to have the best possible chance of recovery. And as more people are being discharged from hospital, combined with those recovering in the community, the number requiring rehabilitation is growing quite rapidly. Okay, next slide, please. So I've put together just a small case study to help highlight and hopefully give you a clearer picture of how occupational therapy can help an individual living with the effects of COVID. So we've got a 48-year-old lady who I've referred to in this case study as Mrs. X, with no previous health concerns. She works full-time and has 2 children and develops COVID before she's had her first vaccination. And she has moderate symptoms requiring a brief hospital admission. She's unable to work or function or drive and complete household chores, and really she finds it difficult to complete activities of daily living. Next slide, please. So afterwards, Mrs. X developed the following symptoms: fatigue, heart problems, reduced concentration, dizziness, breathing problems, headaches, depression and anxiety, and memory problems. And 1 year down the line, Mrs. X is still not back at work. She tried to return to work, but was still experiencing the following: fatigue, depression, heart problems, issues with breathing, and she was still struggling to complete activities of daily living. Next slide, please. So now I'm going to go on to talk about how an occupational therapist could help Mrs. X with her activities of daily living. So the first point I've put is goal setting. So discussing the importance with Mrs. X of grading activities and setting small and realistic and manageable goals. So occupational therapy is very goal orientated and plays a key part in our interventions really with patients. So it might be that Mrs. X's long-term goal is to return to work full-time, or it might be about her goal being about wanting to complete her, activities of daily living and daily routines as independently as possible. So at the very start of Mrs. X's treatment with the occupational therapist and Mrs. X would meet up to discuss what Mrs. X's goals are and what she would really like to achieve. The goals would then set a direction in terms of the occupational therapy pathway. So as our occupational therapist, we would meet up with Mrs. X to complete the goals, and what we would use what we call SMART goals, which stands for specific, measurable, attainable, relevant and time-based. And it's a very popular technique that we use as occupational therapists with regards to goal setting, and it works for a lot of people. So I can't really emphasize enough that a big part of our role is setting goals with patients. Fatigue management is the next point I've put here. So research and literature suggests really that one of the most common and debilitating side effects for individuals from having COVID is fatigue. So helping Mrs. X to grade activities and encouraging her to break these activities down into smaller and manageable chunks will help Mrs. X to regain her energy and will help her to maintain her independence really and do the activities that she needs to and wants to do. So fatigue is experienced by everyone at some point after a period of physical or mental activity. And it's a signal really from our bodies telling us to take a break. So the overall aim of treatment would be to help Mrs. X to replenish her energy and improve her well-being really through advice with regards to pacing, maybe nutrition, good sleep and managing stress. So energy is used physically, cognitively and emotionally. So we'd look at the whole area, all the areas of her life really, and what we could do to help her manage her fatigue. The next point I've put is providing Mrs. X advice in relation to help build her concentration and providing advice and tips around memory strategies. So occupational therapy can be effective to help improve your concentration and memory, with the ultimate aim really of being to improve your function. So poor concentration can impact quite heavily really on our activities of daily living. So might be about speaking to Mrs. X about building up tasks little and often. So an example for that might be setting a timer for a set duration of time, for example, starting maybe at 2 minutes and then for a particular activity, and then maybe the next day adding on, you know, and doing that activity for 3 minutes, just to kind of help her manage in that area. The next point I've put is sleep hygiene. So sleep is vital in maintaining our health and well-being. So sleep deprivation can impact on our physical health and quality of life. So sleep hygiene is a collection of habits that determine the quality of our sleep. So supporting Mrs. X with information in relation to sleep hygiene and giving her advice really about how she could get a better quality of sleep. Maybe discussing what a good sleep environment is, what exactly is a good night's sleep, things that might stop you from having a good night's sleep, and advice maybe on falling asleep more easily. And I guess discussing with Mrs. X steps really to help manage her fatigue. And speaking about maybe taking regular breaks, drinking plenty of water, relaxation, and just really listening to your body. So linking into that really is relaxation and stress management techniques. So discussing with Mrs. X relaxation and stress management techniques that she can apply on a regular basis to help her breathing, and just relaxation methods that she can then apply in her own time, and develop her own response to stress and teach her body to, you know, giving her strategies that she can apply and recognizing when she is stressed or anxious and applying these strategies. So it might be relaxation techniques, tensing and relaxing of the different muscle groups in the body. It might be guided imagery, and encouraging her to do these on a regular basis, morning and evening. Next slide, please. So the next point I've put is promoting a healthy lifestyle. So providing advice and information in relation to living a healthy lifestyle, and discussing the importance of a balanced diet and regular exercise. So being active and eating a balanced diet has many benefits for your health. So including helping to maintain a healthy weight, improving sleep, which obviously can in turn improve your mental health. As you know, probably a lot of us can relate to if we're getting little. Oh, is that, have I gone over my time? Oh, can you hear me?
Yeah, I think somebody's microphone might have come on. If I could ask everyone to switch their microphone off, otherwise we get this horrible feedback. And just to say, Anna, you've probably got about another 5 minutes before we move on.
I'm nearly done. That's fine.
Excellent.
Yeah, so I was just talking about kind of providing information with regards to eating, you know, living a healthy lifestyle. As we can probably all relate to, if we get little or poor sleep, it can lead us to feeling, you know, quite groggy and irritable. So it's really important that to try and promote as healthy lifestyle as possible. Talking about the link between physical and mental health. So physical health problems significantly increase the risk of poor mental health and vice versa. And medically unexplained physical symptoms often have a basis in poor mental health. People with severe mental illness also have significantly high rates of physical illness. So although the mind and the body are often viewed as being separate, mental and physical health are quite actually very closely related. So good mental health can positively affect your physical health, and in return, poor mental health can negatively affect your physical health. Last 2 points. So we might go out to Mrs. X's home environment and suggest strategies and adaptations to make it more manageable for her. Our home is often, you know, somewhere where we can feel quite relaxed and safe and confident. And when this is compromised through an accident or an illness, an OT can help by ensuring that the environment meets your changing needs and new abilities, really. So it might be about offering advice about small items of equipment that she could purchase, or larger purchases. For example, if fatigue is something that she's really struggling with, maybe a stair lift or something like that. So a key part of our role really is understanding how an injury or disability can impact on an individual's daily life, and therefore we can help to enhance an individual's independence. And then the last point I've put would be supporting Mrs X to return to work. So evidence shows that work is good for our health, and it's recognised as an essential occupation to support an individual's health and well-being. So how we could help would be maybe providing advice and strategies to help meet the demands of work. An early intervention, I think, is quite key to help things from escalating. Providing a clear pathway that will support Mrs X to better self-manage in the work. And it also might be about linking in with the occupational health department at Mrs X's work to help educate and support them on how to manage and look after Mrs X's health and well-being, to help bring about a positive change in the workplace, really. Next slide. So in summary, the takeaway message really is, so the role of occupational therapy has highlighted the need to focus on functional wellness and to support individuals to manage symptoms, to live their lives and do what is important to them. And then I've just popped some references there on the next slide, sorry. And then the next slide, that's just to say thank you for listening, really. Thank you.
Very much, Anna. Thank you very much, Anna. We will circulate the slides, so the references will be available if anybody wants to go to the relevant reference and get a little more detail. What I'll do is I'll take questions for you now, Anna, before we go on to Claire, because they are, although you're all under the umbrella of therapy, your disciplines are quite different. So yeah. Does anybody have any questions for Anna? I'll take that silence as a no. Anna, will you stay on the call?
Yeah, I'll stay.
Yeah, just in case there may be things that that come up. I mean, I think from my perspective, it's interesting because this is a hospital health lecture. I think it's the awareness that there's a lot of work that some of our teams do back out in the community and in patients' own homes, and presumably people would access that if they were an inpatient, and then it would be a referral.
Yeah, we can signpost people on.
Yeah,
to get the adequate support in the community, or we might, offer advice or strategies within the hospital environment prior to them being discharged home.
And then if there was ongoing support needed, presumably that would switch across to the community.
To the community teams, yeah.
So yours is a short-term kind of safe back in the home environment from the hospital.
Yes, yeah. And then the work would then continue out within the community.
Excellent. Thank you very much.
Can I just say, Julia, that if anybody thinks of a question while the speakers are talking, you're more than welcome to put it into the chat. So there's a meeting chat on the, I'm just trying to work out which chat, the right hand side of your screen as you're looking at it, and we will keep an eye on that while the conversations are ongoing, and then we can either pull them all in at the end, or we can feed them into the person who's speaking at the end of their session.
And I suppose also, after the session is finished, if you think, oh crikey, I wish I'd asked, if you email Kate, I think Kate, perhaps you could put your email details in the chat. We'll get back in touch with the relevant team member to try and answer your question, because sometimes things hit you afterwards that you wish you'd asked. So there you are, kate.ballinger@nhs.net. So if there is anything that you think of later tonight, or later in the week, then do drop Kate a line. So I'm now going to ask Claire, who's one of our speech and language therapists, to talk to you about the role that speech and language therapy play. Thank you, Claire.
Thank you. So my name is Claire and I'm one of the speech and language therapists based in outpatients out of the Royal Shrewsbury Hospital. Next slide, please. This evening, I'm going to give you a whistle-stop tour, and I probably will raise more things than I answer, so I apologise in advance. But I'm going to talk to you a little bit about the role of the speech and language therapist, some of the symptoms we've seen presenting with people who are living with COVID-19, just what communication and swallowing is in a very quick way. And I'm going to illustrate that through a case study and maybe just direct you to some tips that might be of use and benefit to some of you on the call. Next slide, please. So speech and language therapists, well, the title kind of gives it away. We're to do with speech and language and all things communication, which includes voice. But you may be surprised that we're based in the ear, nose and throat department with the doctors there, and we also treat many throat discomfort sensations. So that may be tightening in the throat, it may be symptoms to do with reflux. And the other big part of our job is about swallowing, both the swallowing of the saliva and our eating and drinking. And I'm going to talk about all of those a little bit more. Next slide, please. So back in September of this year, the Royal College of Speech and Language Therapists, that trips off the tongue, doesn't it? They had some national data about long COVID and speech and language therapy. And this is national data, not local, but I think it's probably fair to say that we would say that we're seeing similar representation here in Shropshire. And we're seeing high percentages of people with swallowing disorders, people with voice problems, people whose communication is affected from the cognitive side. I have to say, I think 23% of more than one need is really low. And certainly of the patients I've been treating, they've come under several categories. None of us from the speech and language therapy team are surprised that, because we understand that communicating and eating, drinking are so integral to our everyday lives, that the fact that that is negatively impacting on people's mental health and well-being is not a surprise. I personally would say that of the many years I've been treating patients, more than any other time, this is a disease that I cannot predict how that patient is going to be until they walk through that door or we meet them for the first time. And a careful assessment is really important because people's needs are changing and people are coming with such a variety of presentations. Next slide, please. So what is this communication? Well, it involves a lot more than just speech and the muscles in our tongue. The speech chain goes everywhere from hearing through the brain and then the articulation. And then it involves the other person. You can't communicate unless you have a communicative partner. And all of this has got very tricky over the last 18 months. These things may not be our friends. Masks have reduced our ability to lip read, and they have made it maybe harder for people to be understood. But for many people with COVID, they may be isolated either through shielding or through illness. People may be at home, and this reduces your communicative need. It actually reduces what you've got to talk about as well, because you haven't been at that party last week, and actually some of life has been very repetitive. And we know that actually depression and many of the mental health mean that actually feeling like engaging in a communication has been a lot trickier. So for all those reasons, we know it's got exacerbated over the last 18 months. Next slide, please. So I'm a great one for busting the medical terminology. So I just wanted to take a second just to touch on. So you will hear disorders of language. So when it is being processed, whether that is via the spoken word or via reading, that is, and the expression via writing or speech comes under the terms dysphasia and aphasia. Somebody is referred to as dysarthric if their voice sounds slurry, and that's to do with difficulties with the muscle strength itself. Dyspraxia is to do with the message from the brain to the muscles. And finally, that dysphonia term is refused when it's a term of voice production. But that may also refer to difficulties with the breathing, and other things tend to come into that category. Thank you. Next slide. So the other half of our role is to do with swallowing. Swallowing is a fast, coordinated process. It involves 5 of those master cranial nerves and 52 muscles working in really quick succession. Every time we swallow, we hold our breath for half a second, and that doesn't seem long until you're feeling breathless, and actually the impact of holding your breath becomes a considerable challenge. But as Anna's already said, we know that fatigue features really highly in that group. And actually swallowing is more than just a swallow process. Swallowing, whether it is your saliva or your food and drink, then it's going to involve you food selection. It involves food preparation. It's all those other things. So by the time somebody's actually got the food from the cupboard and cooked it and got it on the table, by that point, they may actually be feeling exhausted, and the swallow process itself is much trickier. And that's before we start to talk about altered taste or sensation. Next slide, please. So I'm now going to illustrate with one of my patients, who I'm going to call Mrs. A. She is a lady who is a teacher and in her mid-40s. So I first met her in the middle of August, and I was on a phone clinic, voice clinic, with one of the ear, nose and throat doctors. She had COVID back in March 20. She wasn't hospitalised, and her symptoms have been cumulative since that point. She threw herself onto online teaching, and she tried to keep going, spinning multiple plates like many people have over the last 18 months. And by the point we met her in August, she was off work, she was having considerable anxiety and panic attacks, and she was experiencing laryngospasm. Now, this is a horrible sensation that involves a constriction of your voice box, and it may be perceived as like a choking sensation or that tightening. She had considerable voice problems, certainly not that she could go back to teaching. Many of her swallow problems related to her reflux control, which at that point was really poorly controlled. And she had considerable fatigue. Next slide, please. So I prioritised seeing this lady as she obviously was very urgent, and I had her into my clinic the next week. The first thing we addressed was the laryngospasm, and I was able to teach her rescue breaths. After that first session, her laryngospasm reduced markedly, and from after the first week of practicing, those symptoms steadily abated. I then started with her to work on her voice problems, many of which arose from her posture and her breath support. Now, many of us who have been doing this game for 18 months have developed what as speech therapists are terming Teams posture. We're leaning into the screen, trying to get a little bit nearer. Somehow, if we extend our chin, it might help the poor Wi-Fi signal. But that needs to be corrected and need to restoring good posture and breath support. When she first met, she had very shallow breath support, and I worked with her to establish good breathing patterns. When we got her back on her reflux medication, actually the whole of her upper throat sensitivity improved and her reflux control improved, and that all fed in. From the beginning, I worked with her to help her improve where she was at. It was really important she didn't go back to school in September, but that was a really difficult decision for her to make, and we were here to support her. I supported her to go to her neighbour next door, who happened to be a meditation expert, and she really linked in to him to help her to get some great strategies. Next slide, please. Because what we know is that the psychology and voice is very much where art meets science. And yes, she did have the poor posture and she did have the breath control, but actually things had actually got to a point of overwhelm. And actually working with this lady, we were able to get her back to full-time teaching by the 1st of October. We were able to get her to address and to give her some really good techniques to keep her grounded in the classroom and to project well. We know that over the last 18 months, many people's worst fears have been realised and people are bottling up, and this is getting shown in a real variety of manner, but many of those are through the voice and the communication. Next slide, please. So what can we do to help yourselves? Let me send you away with some tips. The first thing is to stay hydrated, preferably non-caffeinated and non-alcoholic fluids. Keeping it, I go back to my trusty friend, these are really dehydrating, and keeping us well lubricated is a really good start. My second is stretch, 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 stretch. We're all holding tension. It may be a lot through this zone and a lot through this zone. So my toe top stretches, stretches. Firstly, every time I hit the Shrewsbury bypass now, I go, ah. Okay, we need to actually turn around wearing masks and actually just start to release some of the tension. It's amazing how that actually just singularly can make a difference. And some shoulder shrugs or some big shoulder rolls just to get that whole area moving. Think about your posture. Are you working from home? Are you stuck in a posture for a long period of time? We need to get up and we need to move. We're designed to not be in one place in a fixed position. My other tip would be to take your medications. There's times and places for changing them, but do so with the support of your multidisciplinary team. So particularly reflux and inhalers. And finally, be aware of background noise. This never happens where everything's all quiet. In my house, it's always the washing machine or something else, but particularly in the car, there's always a lot of background noise. And at the moment when we've got a lot of windows open, again, it's really hard to compete with that noise. Save those conversations for when you're in a quieter place. Just at the bottom there, I've put a website that has got some great tips about speech and language therapy symptoms and some tips for recovery. And you may want to use that as a starting point for any further advice. Final slide, please. So all speech and language therapists in Shropshire, we are employed by Shrewsbury and Telford hospitals. We are a small but well joined up team. So if you would like some further advice from one of us, please ask your consultant or your GP to refer to us if you need further advice. Thank you.
Excellent. Thank you very much, Claire. As soon as you said team's posture, I sat back. And because it's a bit like pelvic floor, it's now going to become one of those reactions that you just do as soon as you hear the words. And I mean, I think that was really, really interesting. When I was a young child, I had a lisp. And when I get tired, it sometimes comes back. But if you have a lisp with your S's and you're sent to see a speech therapist, it's a really hard word to say, but you know, it works. So I think again, really interesting, and I think it's astonishing at some of the sort of physiological functions that we kind of take for granted when we're well, that when you've had a debilitating illness like COVID, and the impact that it has on all aspects of your life. And I think the thing that both you and Anna mentioned was about the mental health and well-being, and how important your physical well-being can have on that. So I'll now open the floor. Has anybody got any questions for Claire? No, it doesn't sound like it. Again, very, very interesting. And again, if you think of any later, or after the session is closed, please do contact Kate, and we will get in touch. But
Kate's got to jump in now, though, Julia, just to ask a question. Actually,
okay.
You know what you were saying about rolling your shoulders and this kind of thing. I can't even remember where I saw it, but I saw a thing about sitting at a desk, and I've always been taught that you sit with your legs at 90 degrees, your back at 90 degrees, your arms at 90 degrees, because that's the best way to be. And this thing I was looking at said that you needed to sit more reclined, because that was the better position for your internal organs, because when you're sitting up, obviously everything's bunched up a bit, isn't it? So any advice on that one?
Carol, do you want to come in?
That might be a question for Carol, or physiotherapist. So that is a perfect segue.
I think from my perspective, I would say is I think there's probably a difference between talking for voice and a general posture. So when you are communicating, we kind of need this kind of core posture. And actually, if you start leaning back, you'll put your larynx into, so your voice box on a stretch the other way, and so that will put equal strain. So for when you're talking, as neutral as possible is helpful. But I'll pass over to Carol now.
Yes, isn't it all to do with the diaphragm as well, that you have to sort of breathe and speak from that place rather than up in your throat? I'm sure I've seen that.
So it's just using the whole of your upper chest to support that voice. And the diaphragm actually isn't under our control. So we just work really hard on deepening the breath and using the core muscles at the top of our chest to support the voice.
Excellent. Thank you. Well, that's been really interesting, Claire. Thank you very much indeed, and perfect timing. We'll now move across to Carol without a presentation, who's going to speak to us, and we will circulate the presentation later. And don't do the 4G leaning forward. We'll hopefully, the signal's pretty good on the phone, Carol, so carry on.
That's fantastic. Yes, thank you very much. So as I say, I'm having to do this via my phone, so apologies for my IT problems. However, just to deal with the posture question, everybody's right in the fact that we need a different posture does actually suit a different function slightly differently. So as Claire says, with the breathing and with your voice and what have you, then that neutral upright is fine. Yes, you don't want to be scrunched too far forward, because yes, it does compromise your abdomen and how that works. So my advice comes along with everything else, and that is change it regularly. Whatever position we're in, our joints don't like to be stationary in one position for a long period of time. We have a blood supply to our muscles and other organs is quite good. But when it comes to our joints and our joint surfaces and our cartilage, then there isn't actually a blood supply particularly to it. Those tissues get their nutrients by movement, by squashing and relaxing. So every time we put a little bit of pressure on our knees or our ankles or our feet, or we squeeze our hands and relax, we're moving the joint fluid around, and that's how it gets its nutrients. So everybody's right. It's a little bit of everything. It's keep moving, keep changing that position, get up, walk round, sit back down again, check in with it, have those shoulder rolls, whatever you need to do. So hopefully that sort of tackled the posture side of things. I wanted to talk a little bit about, yes, about the role of physio, but just again have a bit more of again, like the others have, some practical tips and strategies to use that perhaps comes more from a physio point of view. So I'm just going to say I started this with my headphones in, but I'm getting some funny feedback. So let me just take my headphones out and turn them off.
I know. I'm going to, I think we just lost Carol, but I think we're just admitting her again.
Sorry about that.
That's okay. That's
feedback
you.
my headphones as well. Can you all hear me?
We can.
Can't hear you. Why can I not hear you? Oh dear. Yeah. Probably still connected there now. That away. Can I hear you?
We can hear you, Carol. Can
Brilliant.
you...
Lovely. Sorry about that. Okay. I think, first of all, one of the things for me that Claire's just mentioned is that everybody is different, and every person who talks about their COVID recovery talks about a slightly different emphasis, so many different symptoms and difficulties and so on. So there isn't a one size fits all, and of course new things are coming along all the time. A point that Anna made greatly, and that is with the OT's involvement, is about pacing. And we also have talked a lot about in the acute stages of COVID about breathing control and how we manage our breathing. But when we're in the rehabilitation phase, it's actually quite difficult to know how hard to push yourself. How hard do I work before I have a rest? So I wanted to try and perhaps talk about quite a simple system that we can use to try and sort of, work out what is our effort. It's your effort. It's not my effort. It's not next door's. It's the effort that you're putting into something right now, this moment. Again, it's yourself, and it's what you did, not what you did an hour ago, not what you did pre-COVID, not what you'll do tomorrow. It's in this particular moment, it's how much effort you feel you're putting into your activity. So one of the simplest things to use, and some people might have heard of this, is something called the rate of perceived exertion. And there are lots of different versions of this, but one of the easiest ones to look at is the scale of 0 to 10. Where 0 is you are completely and utterly relaxed, you are not necessarily asleep, but you're not aware of your body at all. You're not aware of your breathing, you're not aware of your heart rate, you're not aware of your muscles. Totally relaxed. 10 is where you are absolutely on your knees. You cannot speak. Your heart feels like it's pounding out of your chest. You can't move a single joint or muscle. So that's your sort of scale. And what we need to do to make a physiological change, we need to push ourselves hard enough so that our lungs and our heart and our circulation responds to that to make improvements. And if you can work for short periods of time at what I would call what we'd say is a 7 out of 10, then that is going to make those physiological improvements. The rate of perceived exertion thinks about 3 things. It's heart rate, it's breathing, and it's how much effort your muscles are putting in. So in some activities, they might make you very, very breathless, but you don't particularly notice your heart racing or that your muscles are working hard. That doesn't matter. That's still
a rate of perceived exertion of 7 out of 10. It may be climbing the stairs, for example, that your legs might feel really, really weak, and they might be working really, really hard to get you to carry whatever it is up the stairs. Maybe it's the washing or, you know, your laundry basket, which should be easy, but it's not anymore. Then it's 7 out of 10 for what your legs are feeling like or your muscles feel like. Or it may be, particularly along with your, if you get anxious or you're worried about things, then it might be that your heart rate goes up. And that again is a 7 out of 10. So as my two colleagues have already said, the anxiety or nervousness about thinking something takes effort, and we need to make sure that we recognise that. So hopefully, as I say, we've got this rate of perceived exertion, 7 out of 10, and it can be one or all of those symptoms or any combination of. And if we maintain that level of activity on and off for about 30 minutes, so it might be that you are doing a particular task, you might be having a shower and getting changed, or it might be that, yes, you're unloading the washing machine, or it might be what you need to do at work, whatever, then you don't do it continuously, but over a period of about half an hour, you are being quite active, and then you rest for a moment, you're quite active and you rest for a little while. If you think, right, I'm going to, as I do this, I'm going to get to the point where I feel this is 7 out of 10, and then I'm going to back off for a couple of moments, a couple of minutes, let everything settle down, go back to it. Back off for a couple of minutes, go back to it. You are going to get a physiological change, and you're going to get some improvement. I said it's now. It's not how you were yesterday. It's not how you're going to be tomorrow. It's how that feeling is now. So that allows it to take into consideration everything else you've done today. So if you have been talking a lot, perhaps you've had friends round, or you've been talking on the phone, or you've been on a meeting and you've been doing a lot of talking, then, as Claire's explained, there's a lot of muscle effort and a lot of control required, a lot of breathing control required. And it may be that you've had quite a long spell of quite high intensity work, and you do need to remember those things when you get to the end of the day and you think, oh, I haven't really done much, or am I going to get better? Actually, you have challenged yourself. So if when you come to do get the washing out the machine and you've had a busy day doing other things, you think, actually, well, I've already done 3 or 4 episodes of 7 out of 10 activities. So it might take you longer today to get the washing out of the machine than it did yesterday. That doesn't matter. It's as long as you still achieve that level, you will make those physiological improvements. And in a week to 10 days time, that's when you see the benefit. So you're not going to see the benefit tomorrow of what you've done today. It does take a week or 2 to actually feel those benefits. So hopefully there's a few different things there for you to consider when you're thinking about your both your physical and your mental recovery. And if perhaps you're feeling that today you haven't been able to do as much as yesterday, don't think about how much you've achieved, think about how hard you'd worked. And if you feel, yeah, I have worked at that level today, then that's great. Be kind to yourself. Give yourself that chance to recover and improve. But obviously not sitting still and doing nothing. So it's be kind, but be strict, is a bit of a message. Anybody at any time cannot maintain a level of training and improvement every single day. You know, even Usain Bolt can't run a 9.9 second 100 meters every day. he has to build up to that, and then he has to taper back down from that, and then he will build up to it again and taper down to it again. So have your days of rest, have your days where I think Anna would agree with me, where you do more of your sitting down jobs, telephone calls, answering emails and those sorts of things, or half a day doing that, and the other half of the day or the next day doing your more active stuff. So getting out for a walk, walking the dog, I say doing the ironing, all sorts of different things. It doesn't really matter. So, but balance those things out. And if you want to think about how you're balancing them, think about, have I achieved that 7 out of 10, whether it be mental activity or physical activity? And if you have, give yourself a big pat on the back and a big reward. Okay, thanks very much. I think that's probably what I wanted to say today. So if anybody has any questions, that would be great.
Okay, that's great. Thank you very much, Carol. Has anybody got any questions for Carol? I mean, I think the point, there is a hand up, Karen. So I'll go to you first and then I'll make my point afterwards. Karen.
Sorry, Julia.
That's right.
I'm a bit concerned with what you said. I've 20 months nearly of long COVID, and getting out of bed. I work on the spoon theory, which is what I was told by an occupational health for fatigue. For me, getting out of bed and trying to have a shower is like 3 of my spoons of 8 a day. I cannot go over that 8 spoons because the next day I will be in bed and not be able to get out of bed. And I think by saying by the end of the 2 weeks you might have improved, I'm 20 months on and I'm no better than I was August of last year. I've been told not to increase what I'm doing, to stick with what I'm doing, with the 8 spoons a day. But some days I can be nearly a week without getting out of bed. And for someone, like, I agree with what you're saying, but for someone with long COVID, that is a very difficult thing to do.
With your, I suppose, I do totally get what you're saying. If I think we're probably approaching the same thing, but from a slightly different angle. So I'm saying me 7 out of 10. You're saying you're 8 spoons a day. Absolutely right. I think that there are, however, limits. So I'm quite sure that if you did 4 spoons today, you couldn't do 12 tomorrow.
No way.
No. I think it's more a case of how you balance those out. And I think everybody's response generally is quite, as we've said before, is very, very different. What might be worth thinking about is the trouble is our very small changes are really quite difficult for us to see sometimes as well. And I think if you are managing to work within your 8 spoons a day, that's absolutely awesome, because if you weren't achieving it, you would be 10 times worse than you are.
Yeah.
So you are plateaued at the moment.
Yeah, definitely.
I perhaps should have put that in, really, just thinking about time, that you will people do plateau, and this is one of the difficult things at the moment, is that trying to work out how long everybody's plateaus are with this condition. But that's where I was saying, trying to be kind. Don't try and get too frustrated. I can't imagine how it feels to be that 20 months down the line and still only being able to do your 8 spoons a day. But as I say, if you weren't doing them and achieving them, this is where you've got to be kind to yourself. You would be so much worse.
Yeah, I totally agree.
You are giving yourself every opportunity when your body's ready to make the improvements.
Yeah, because when I came out of hospital, I had no dealings with anybody whatsoever. And I was told to increase my activity every single day. Well, come August, I could do nothing.
No, you can't.
So it's good that people perhaps nowadays get seen by a physio and whatever, but when I came out, and still to this day, I haven't seen anybody.
No.
I think a lot of us feel like we've been forgotten. I was told by the Health Trust yesterday that there's nothing else they can do for me, to go back to the GP. And
sorry, who said that? Sorry,
I spoke to the long COVID clinic yesterday, and she said that there was nowhere else to refer me.
Right.
And, you know, I think we need a bit more understanding.
So Karen, have you said you haven't had any therapy support since you left hospital?
No, all I've had is a respiratory consultant one appointment.
Which is slightly different, and it may be that from a respiratory point of view they've done all that they can, but it sounds to me as if there may be other things from a therapy point of view that could help you. So I'm looking to Carol, but I would urge you to go back to your GP.
Absolutely.
And ask for a referral. You can say, because you know any one of the therapy disciplines could probably help.
Especially speech therapy would be a big help. And because swallowing is an issue, but that's never been mentioned. You know, I've had so many appointments, I filled out so many forms with all my symptoms, but I've not been offered anything. So I think coming on here has opened my eyes to what is available.
I think we've got some people joining. Can I ask you if you could go on mute? And can I point out you joined an hour late because we're just about to finish. So so I think, and I'm looking at Claire and Anna and Carol, I think the best thing to do would be to go to your GP and ask for a referral.
Yeah, definitely.
Absolutely right. Has anybody suggested that you are referred to the pulmonary rehab team, because they have been trying to do some so the team that actually do the pulmonary rehab for people with other chronic respiratory diseases have taken on some role with trying to do some rehabilitation for folks with long COVID. So again, that's a point. Your GP should be able to signpost you to them. But then again, yes, the community OTs, I'm sure Anna will say, and through speech and language is all through the hospital. But again, you know, keep pushing your GPs to refer you. Definitely.
Yeah, thank you. Thanks, Julia, for letting me join.
No, that's fine. Is there anything, Anna or Claire, that you wanted to add? Anna, you're on mute. Never gets old.
Is that better? Can you hear me now?
Yeah,
no, it was really interesting, Carol, what you were saying, and it links quite closely, I think, into the important role that we play as occupational therapists with regards to goal setting and setting small, you know, manageable goals with the aim of reaching a long-term goal, and how that is all quite closely related, really. But Karen, from what you're saying, I definitely think it's worth getting a referral to occupational therapy for advice with regards to, you know, fatigue management, goal setting, and things like that. I definitely think that you do need a referral there.
And
Can I just quickly add in that actually my case study, you know, she came to me in August and she just said, I wish I'd seen you 12 months earlier. I'm not sure whether speech is going to be relevant for you. If it is, I hope we see you in a clinic soon. But what I would say, if there are other people on this call, I think because, as we have described, the first 6 to 9 months particularly, a lot of the services were really locked down, but actually I think now things are moving forward in a more systematic way, and actually please just get in touch. You know, there are people out here and we can help you and signpost you onward.
So you
you.
would do that through your GP though, rather than through the clinic that you're going to. There is a question. So the pulmonary rehab clinic that you mentioned, that would be through the GP as well, would it?
Yes,
Karen?
it is. Yes. Yeah.
So that might be worth, and your GP may not even know about it. I'm sorry to say, but if you say that you've been on this health lecture and that you had the combined wisdom of the various therapy departments and they've recommended it. There is a question in the message box saying, are all the therapies involved in the long COVID clinic? Is that the pulmonary rehab clinic, or is that I'm not sure what the long COVID clinic is. Claire, you asked the question, what do you mean by the long COVID clinic?
Hello. So my impression was that there is a long COVID clinic, but I am not aware as to whether or not all the therapies are actually involved in providing that clinic, or is it purely by medics?
I think it's medics, because that's who I've been speaking with, the long COVID team, over the last 2 years, and I've only actually been offered a medic and PTSD counselling.
Oh, which is really important, but it sounds like they're missing out on all of these amazing specialists.
So absolutely. And I
I'm
think
sure if things are imminently changing, I know one of my colleagues has actually started joining the multidisciplinary team discussions, and that's literally been in the last fortnight. So let's all hope that actually things are going to be a little bit more joined up, and people can access the services they clearly need.
And one of the things in the trust, which is kind of related, although it's slightly different, is that we now have, so it hopefully will be better for patients going forward. And we still have, I think today we had 36 patients with COVID in the 2 hospitals. So although the numbers are nothing like what they were, 18 months ago, and we aren't seeing the numbers on ITU that we saw. I think there are 5 across the trust at the moment on ITU, but it is still with us, and we're starting to see flu patients being admitted with flu as well. So there's a lot of respiratory type. But one of the things that we've introduced is that every ward now has at 9 o'clock a board round where they do a very quick dot around all of the patients, the medics, the nurses, the therapists, and look at what, and I've been in on 3 of them, and it's picking up that sort of thing that perhaps wouldn't automatically have been thought about as part of discharge arrangements. So I think it will get better, but I think there probably is a cohort of patients, because in the early days of COVID, nobody really knew what we were dealing with. The people that were in the hospital, I came in every day for the first wave. I was terrified, bluntly. I thought, COVID was waiting around every corner to infect me and my family. So we didn't know enough, the PPE situation, all of it. So I think if you were unfortunate enough to be one of the early victims of COVID, I don't think we did have the support in place, but it is there, Karen. So do go back to, and anybody else that's listening that's thinking actually what Anna said or what Claire said or what Carol said, that really strikes a resonance with me. Please go back to your GP, and they will refer you, whether it's to the therapy department or to the pulmonary rehab clinic. There is support there, so please do make use of it. And what I was going to say, but in effect, Karen, you kind of said it for me, was that what I've heard from each of our 3 speakers is that everybody's journey will be different, and everybody's 70% or 8 spoons will be different. And what you mustn't do is kind of beat yourself up, because it's a disease that we don't know. Last month's health lecture was by the R&D team about all the work that they had done in the very early days to introduce new regimes for dealing with COVID in months, weeks in some cases, whereas in the past ethics committees it would take years to get approval for research trials, and that was, so this is something that is completely new, and we are sort of learning as we go along. And I think that is a point that we do need to think about those early diagnosed COVID patients, and how we're supporting them. So I'm anybody that's on the call today, and part of Kate's role and Hannah is community engagement. So that's one of the messages that we can take out when we go out to the communities, to say, you know, there is help available. Please, you know, don't feel abandoned, because none of us know how long this journey is going to take, but it is a journey with an end. And what was interesting is listening to Anna and Claire. Anna's focus on returning to work, Claire's on don't return too quickly. Again, it's, you know, it's getting it right for the person, and it will be different for every person. And I think it was, you know, there isn't one size fits all, so what one of the speakers said. So I hope that tonight has given everybody something to think about. If there's anything that you do think about that you haven't had the chance to ask now, then please do drop Kate a line. We will be sending the slides around, plus Carol's surprise slides, which we haven't seen, but but you know, that would be very useful. And you know, if there is anything at all that, you know, that we can help with, them, please do let us know. And I'd just like to end by saying a very big thank you to Anna and to Claire and to Carol for coming along tonight, and you know, really giving us a completely different perspective on the COVID. Oh, and Claire, sorry, we've got no, sorry, I did say that. It's all right. So for giving us, you know, a different perspective on the management of COVID, because it has, I think a lot of the focus has been on a very medical model, but you know, there are other equally important functional models that we need to be considering. So thank you very much indeed, ladies, and I'll wish you all a very good night. Thank you.
Thank you.
Bye now.
Thank you.
Bye.
Bye.
Thank you.